My name's Yvonne Burks. I'm one of the Associate Directors of the school, and I'm going to chair the sessions this afternoon. We've got a real mixture of topics, and we're going to start with Josh Weiner, who is visiting from the States. He's a distinguished professor at RTI, and I don't think there's much Josh hasn't done, looking at his CV, but he's going to attempt to bring all his wisdom into half an hour for us and tell us about developments in social care in the US. So, Josh, thank you very much and welcome.
Thank you. Thank you. It's a pleasure to be here. So I think there's a lot to be said for looking internationally in social care as well as other areas. Basically, all developed countries are really addressing the same set of issues. Their responses are very different. In some cases, the response is to essentially do what you're doing here in England. In other cases, they're doing something fairly traditional, but it's a different response, which is a reminder that policy decisions and developments are not foreordained. And then in some cases, countries are doing things that are new and innovative and really, you look at them and you'll say, well, maybe we can try that here in England. So basically, I'm going to start by giving a little bit of context about social care in the United States, but I want to spend the bulk of my time talking about three issues. One, the impact of the Great Recession on social care. We've already heard a little bit about that today. And then talk about initiatives to expand home and community-based services. And then finally, efforts in the United States to integrate medical and social care, and then conclude with some implications. So social care in the United States. So we're a big country. We've got lots and lots and lots of providers. We have over 15,000 nursing homes, 30,000 residential care facilities, which are sort of like care homes at the lower level. We have over 12,000 home care agencies, 5,000 adult daycare programs, and thousands of other social care providers. The system is very heavily dominated by for-profit providers. Most expenditures are for institutional care. So in social care, especially for older people, we talk a lot about the impending explosion of the number of older people, and we often talk about it as if demography is destiny. There's some aspect to that, but I've come to be quite modest about what the potential impact could be, and this is one slide that helps to illustrate this. So the blue is the number of people in nursing homes in the United States on an average day. And the green is the number of people age 85 and older, obviously the population most in need of long-term care, social care. And what you can see is basically that the number of people 85 and older has roughly doubled. The number of people in nursing homes over the last 20 years has not increased at all. It's really quite remarkable. It hasn't increased at all. Maybe during the questions we can come back to that. So we have a very complicated system of financing. On the healthcare side for older people, we have our Medicare program, which is a universal national government health insurance program for older people. It basically doesn't cover social care, but it does cover short-term nursing home care and home care, generally coming out of the hospital for rehabilitation and short stays while you recover. It's very medically oriented. But the bulk of financing for social care in the US is through Medicaid. And this will look very familiar to people here in England because it's basically a means-tested system jointly financed by the federal government and the states. And it's means-tested. Most of the people in nursing homes have their care covered by Medicaid. It's basically an entitlement program. It's complicated, but it's basically an entitlement program. So if you meet the eligibility and you get the services, the state has to pay for it. The states have substantial flexibility in terms of eligibility, benefits, reimbursement. But there are other sources of financing for social care. At the national level, there are a number of small programs. States have a number of small programs. Private long-term care insurance does exist. Unlike here in the UK, there are about 7 million people, 8 million people in the US who have long-term care insurance, but that system is basically collapsing for a variety of reasons that maybe we can talk about later. And because it's a means-tested program, people have to pay out of pocket, and costs are very high. So a year in a nursing home costs about £53,000. Expensive. People impoverish themselves, end up on Medicaid. So that's kind of the system we're dealing with in the US. So let's turn now to the issues. So the impact of the Great Recession on social care. So we've heard a lot about how there have been very substantial reductions in expenditures and number of people served here in England. That's not what happened in the US. So the recession, the Great Recession, started in the US, and it was pretty serious. The economy contracted by almost 3% in 2009. New housing starts fell by almost 2/3 between 2006 and 2011. The unemployment rate doubled up to nearly 10%. We were hurting. We were hurting. And that really showed up in the national budget deficit. In 2009, the budget deficit was nearly 10% of the gross domestic product, but we recovered relatively quickly compared to England and especially compared to Europe. So the response of the national government in the US to this recession was basically fiscal stimulus, to try to spend more money to try to get the economy going. And the key aspect of that was the American Recovery and Reinvestment Act, as we call it, ARA. And for social care, the most important characteristic was it had a temporary increase in the federal matching rate for Medicaid. The way it works, every dollar that the state spent on Medicaid would be matched to some extent by the federal government. And so for a limited period of time, the national government increased that matching rate to try to keep expenditures up for Medicaid, up for social care, as well as a number of other Medicaid expenditures. In addition, the Affordable Care Act, the major health reform legislation that was passed in 2010, included a number of provisions to try to expand home and community-based services, and the carrot was basically an increase in the federal match for Medicaid for those services. So this is what happened to social care expenditures for older people and younger people with physical disabilities between 2007 and 2013. They increased overall from $69.5 billion to $88.9 billion, about 17% higher in 2013 than in 2007. This is total social care expenditures for Medicaid, including mental health expenditures, including expenditures for people with learning disabilities. That increased almost 40% over that time period from 2005 to 2013, from $104 billion to 2013. Although starting in about 2010 as you can see, the rate of increase started to slow down. So here's the average annual rate of growth over that time period. In the period before the recession, 2000 to 2005, the rate of increase was 7.1%, and that rate of increase declined over time, but it continued to be positive. And basically, for 2011 to 2013, when the U.S. was pretty much done with the recession, it really fell to a fairly low level of 1.6 percentage points. And what that reflects is a political decision, not an economic decision. Because in 2010, a number of very conservative Republican governors were elected, and it was part of what they wanted to do to try to reduce the rate of expenditures in Medicaid and other kinds of settings. So, as I mentioned, not all expenditures are through the Medicaid program. We have a number of smaller programs. The Administration for Community Living runs a number of those programs, which are not entitlement programs. They're appropriations. That means the government specifically decides how much they're going to spend. And as you can see, from 2006 to 2013, basically flat. Nothing going up very much. It increases over that time period a little bit, but not much. So big difference in the response between the entitlement programs, Medicaid, and the appropriated programs, the Administration for Community Living. So in social care, as I said, in the U.S., with some exceptions in some states, social care basically survived the recession pretty well. It did that because Medicaid is an entitlement program, and it really requires an active intervention by the government to reduce expenditures. And politically, that's not necessarily easy to do. As I just mentioned with the Administration for Community Living, if you're not an entitlement program, you did less well in terms of expenditures. So as I also said, what we found was that the government provided incentives as part of its fiscal stimulus to keep Medicaid expenditures up, and there were incentives in the health reform bill to do that as well. There are also certain legal protections for especially home and community-based services. The Supreme Court in the U.S. has essentially ruled through its Olmstead decision that there is a limited right to home and community-based services by people with disabilities, making it legally more difficult to try to cut back on services. So the second area I want to talk about is the expansion of home and community-based services. Importantly, in the United States, as well as I think most other countries, there is now a broad consensus that is across both liberals and socialists and conservatives to try to increase home care and reduce nursing home use. And there are three rationales for that. First, it's what people want. There's a lot of evidence in the United States about that. People want to stay in their own homes. They don't want to go into nursing homes. The second rationale is that there's better quality care. And while there are some studies that show that people in receiving home and community-based services have a high level of satisfaction, there aren't really much in the way of rigorous studies about that. And the third rationale is that it's less costly, which is a highly contested and often bitterly debated issue in the U.S., but the policy has gone on. It's not open for question anymore. the goal is to expand home and community-based services. And so this is the percentage of Medicaid social care spending for home and community-based services for the aged and physically disabled from 1995 to 2010, or actually to 2013. So it steady percentage up, starting in 1995 at about 18%, and now over 40% of expenditures are for home and community-based services. So we've really moved that substantially, although if you decompose it, even for this population, the younger people with physical disabilities have done much better than the older population in terms of changing the balance of the delivery system. This is the growth in Medicaid home and community-based service participants overall, including the aged, the physically disabled, people with learning disabilities. And as you can see, it's gone up over time, but it's kind of flattened out as around 2008. Gone up a little bit since then, but really not seeing a growth in the number of participants. And that is reflected in the waiting list. So most of our spending for home and community-based services under Medicaid is through this so-called home and community-based services waiver, which allows states, unlike the rest of the Medicaid program, to have waiting lists. And as you can see, that waiting list has gone up over time. It's kind of stabilized a bit, but it has been going up. So part of what part of what we're trying to do in the U.S. is not just increase the number of people, not just increase expenditures, but to try to redefine home and community-based services to make it more consumer-centered, to have more consumer empowerment. And there are three mechanisms that we're trying to do that. One are the so-called aging and disability resource centers, more consumer direction, and through this money follows the person demonstration. And so since we have such a fragmented financing system, what the aging and disability resource centers try to be is a single point of entry into the long-term care, the social system that everybody can enter into, gather information about what's available in the way of services and financing so that they can do that in a comprehensive way that meets the needs of the individuals. Consumer direction, this is very much like the kind of personal budgets that you have here in England. Consumers can hire, fire, direct, train, and schedule. It was initially advocated by younger people with physical disabilities, but it spread to really all types of people with disabilities. And a number of states, including Wisconsin, Oregon, Washington, California, have this as a major part of the way in which they provide services. These paid caregivers tend to be family and friends, and they tend to be much less well paid than agency providers, generally around the minimum wage. And so there are two initiatives that are currently underway in the US that have direct implication across social care, but especially affect consumer direction. And the first, which will resonate here as well, is that there is a major push to increase the minimum wage, which is currently around $7.25. And California and New York are basically going to double that minimum wage to about $15. So that's going to substantially increase the cost for the Medicaid program. Moreover, these kinds of workers have typically been exempt from overtime requirements, but one of the changes that the Obama administration has done is to make these workers now eligible for overtime. And these consumer-directed workers often are live-in workers, typically work 10, 12, 14 hours a day. So they're now going to be eligible for time and a half. So that, too, is going to substantially increase expenditures, or the push for expenditures among for Medicaid beneficiaries. So not quite clear how that's going to play out, but it's going to be a major issue, and either government is going to have to spend more money or they're going to have to find a way to cut back on services. The third thing is this money follows the person demonstration, which has not been all that successful, but it has really stimulated a lot of thinking. So I've been doing social care since 1975, and since 1975, the emphasis has been to try to intervene before people enter nursing homes, to try to divert them, keep them from going in. And what this approach does is find people who are already in nursing homes, try to move them back into the community. That's been difficult to do. Over the last 10 years, there's been maybe 7 million people admitted to nursing homes, cycled through. They've only managed to move out about 51,000 people. So they haven't succeeded in moving people out, but they've stimulated a lot of thought about how to try to increase the turnover and the movement from nursing homes back into the community. So the third area I want to talk about just briefly is the integration of medical and social care. People have been coming from England to the US to talk to me about integration of health and social care since at least the 1990s. We don't do it very well, but everyone's looking for ideas. So the basic problem here, as well as elsewhere, is that medical care and social care is fragmented, but people with disabilities aren't fragmented. They have a combination of health and social needs, and the current system doesn't deal with that very well. Different levels of government dealing with it, different programs, and so the hypothesis is that integrated medical care and social care can result in a win-win situation, both better care and lower costs. So there's plenty of evidence that people with disabilities have high medical expenses. Over on the far left is the average healthcare expenditures in the US for older people who don't have disabilities, and it's going to stair step up. So on the far right, you have people who have more than 3 problems with the activities of daily living, so over 4 times as much in the way of medical expenditures. And there's plenty of evidence in the US that a lot of those expenditures are unnecessary. So there's a large literature on the percentage of potentially avoidable hospitalization among nursing home residents. You can pick your choice in terms of which estimate you like best. I like the one at the bottom the best because I worked on that study, but you could choose others. So what is now going on in the United States is this so-called financial alignment demonstration, which basically takes people who are eligible for both Medicare and Medicaid, so both basically older people and some younger people with younger people with disabilities who tend to be low income, and basically put their expenditures together, make per person contributions to managed care organizations, and say, you are now responsible for everything, the medical care, the social care, and everything in between, and you're getting this pot of money and no more. So it has basically, it is internalizing all of the costs and all of the trade-offs within one organization on the assumption that that will make the organizations more cost-conscious and will try to provide the most efficient system that meets the needs of the individuals. So a number of issues on that, basically around will it work and will it over-medicalize the long-term care system? So those are the three issues. Implications for England. Despite the differences between the two countries, we're dealing with the same issues. We chose a different path in terms of dealing with the economic downturn and in a way that protected social care. Both countries are trying to expand home and community-based services. We're doing it largely by trying to target people with quite severe disabilities who meet the level of care that would be required in a nursing home. And then finally, we're trying to integrate acute and long-term care, social care, through managed care organizations, third parties that don't stand in either the healthcare or the social care world. And it's trying to find those kinds of third-party organizations that's difficult and really doesn't kind of exist here in the US or the UK. So no doubt with the aging of the population, these issues will not go away, and so we can all meet again at future conferences to discuss this issue. Thank you.
I think we might have time for just maybe one or two really quick questions if anybody has one. Jules?
The US experience?
So RTI has the government contract to evaluate the demonstration, and we are embargoed from saying anything about our results so far. But I will say, just as a kind of preliminary thing, that enrolling people in the managed care organizations has proved to be a much greater challenge than I think the states and the managed care organizations thought it was going to be. You're dealing with people who, by definition, have substantial disabilities, and many of which are cognitive in nature, and getting them to understand this radically new system, especially after they've had a long history of relationships with an established set of providers, has not been easy. Has not been easy for the providers who now have to deal with a variety of managed care organizations rather than just sending their bill into the local authority. So the implementation issues are enormous, and government likes to move quickly when they're looking at the next election and trying to get savings, but I think this is an area where slower is better.
One more quick one at the front, gentleman in the blue T-shirt.
Medicaid. Are the barriers to access it increasing in what sort of way?
The barriers
to access Medicaid. The ones that is means tested, are the tests becoming more and more stringent?
I'm sorry, is what?
Are the tests to access Medicaid becoming more stringent?
Well, so the financial standards have not changed very much. Some states have tightened the definition of nursing home care, which affects both people trying to get into nursing homes, but also who would be eligible for home and community-based services. The nursing home supply has not increased, but occupancy rates are the lowest in my 40 years of working in the field, so that's not particularly a problem. There is a huge disparity in reimbursement rates across providers between private pay and Medicaid, between Medicare and Medicaid, and basically all providers prefer private pay residents or private pay clients to Medicaid. But as I mentioned, 2/3 of people in nursing homes are Medicaid beneficiaries. So the reality is that the costs are so enormous that basically few providers can avoid dealing with the Medicaid system.
Okay, I think we'll probably have to move on, but if we can just thank Josh very much. Very interesting indeed. Also delighted to welcome Geraldine MacDonald, who's moved from University of Belfast to Bristol, where she's taken up the position of Professor of Social Work. And Geraldine's going to talk to us about RCTs, which will be either close or not to your hearts, but I'm hoping that we'll get some interesting debates from that as well. So, Geraldine, thank you very much.
Thank you. Well, if it's close to the hearts of 3/4 of you, it'll be a minor miracle will have occurred in the last 30 years. So, I was asked to talk about RCTs and social care, and lest I run out of time, the plain language summary is in the subtitle. Okay. What I'm going to do is to review, thank you, some of the usual or historical objections, maybe current objections, that particularly social care researchers make to the proposal to use RCTs more in this field. I then want to take a serendipitous look, really, at what I've been able to ascertain as the state of play in relation to trials and adult social care. I then want to consider some of the lessons learned, and then to conclude with considering, or for some of us reconsidering, some of the challenges. So, I'm just trying to work the technology. I haven't had a go at this yet. This one or? Oh, that one. Oh, okay. I hate technology. Right. Just to, before we go on though, just to give a very brief resume of the design that we're talking about, because it's not very complicated. It involves recruiting a number of people, or maybe teams, or care homes, or agencies, and then using some method that means people can't know which group they'll end up in, randomly allocating those individuals or teams or groups to one of two groups. One of the groups might be doing something new or be asked to deliver a new intervention. Those in the other group will carry on either with business as usual or in some cases with nothing happening at all. And as time goes on, and it could be months or weeks or years, we track, having decided what the appropriate outcomes and measures are, we track the impact of those interventions on each group with a view to ascertaining whether the interventions made any differences, for better or for worse, compared with treatment as usual or no treatment. And the thing to bear in mind is that the only claim to fame in a trial is that it does a better job than almost every other design in enabling us to draw a causal connection between the impacts that we measure and the intervention that we're evaluating. And that's really the only thing that marks it from other study designs. So when are they appropriate? Well, I've pretty much given my view on that. They're really only appropriate when you're wanting to know whether something works. If you've got any other research question, they're probably not even on the agenda for consideration. And I want to come back to the when towards the end of this presentation, because there's another interpretation of when that we need to consider. But it's not just when you want to know something, but when you've got good reason or you don't really know whether something's going to work. And my own view after 20 or 30 years in this business is that the reason it's particularly challenging for social care researchers is that because we're in this business and because it's so relationally based, it's very difficult for us to believe that anything that we do with good intentions, that's well-resourced and supported particularly, cannot possibly be anything but a good thing. So why would you withhold the intervention from somebody in a control group in order to demonstrate the worth of an intervention? And that's really one of the two main arguments against randomized trials that people will produce, that they're unethical. For that reason and for some others that we'll revisit again at the end of the half hour. But the other argument, which in some sense carries a little bit more weight for me, is that you can't do them in social care. They're very difficult, people say. And the reason I say I've got a little bit of sympathy for that is that particularly in the UK over a number of years, we have had some spectacular failures with randomized trials. But my argument, and I'm sorry to keep saying this, but I will come back to it later, is that it's not the design that's wrong, but the way we have commissioned and designed and implemented them. But nonetheless, those early years failures, if you like, of trialling interventions in the UK have left a legacy that they're really not very easy to do. But there is another challenge that I encounter much more often, and it's much more insidious and difficult to grasp. And I want to show you two quotes. Don't try and read both of them, but perhaps you'd like to look at the one on the left. It's a little bit easier to read. I could have picked hundreds of these, but I've just picked one from 2005 and one from Ruth Northway in 2013 that just illustrates what to me is a sleight of hand that people engage in when they want to distance themselves from randomized trials. So we start by acknowledging that there's some merit in them, but then the argument goes, it's important not to take too narrow a view of what counts as evidence. And Marsh and Fisher say something rather similar. But both of these arguments are really rather straw person arguments, because I've yet to meet a trialist who says that the trial is the answer to everything. I've yet to meet a proponent of evidence-based practice who says research is the only information we need. And this is a little journey back in time, really. This slide is from the very early days of the Cochrane collaboration. Be probably quite difficult to find now. But it was used to demonstrate the place of systematic reviews, and embedded within that, of course, a lot of trial evidence. It was used to demonstrate the place of systematic reviews in developing improved decision-making in health. And you don't need to look at it very long to notice that nobody, even in the 1990s, the early 1990s, ever argued that trials or systematic reviews were anything more than one brick in the wall of evidence-based practice. Advocating randomized trials, or indeed systematic reviews, does not mean that you eschew the voice of service users. It doesn't mean that you say there's no place for professional judgment. It doesn't say a lot of things that quotes like the ones I showed on the last slide are really engineered to induce one to think. What is interesting about these quotes and these arguments is that you would think we were drowning in randomized trials. And it is quite extraordinary. And what I thought I would do in moving this discussion forward, really, was that I found, since I've moved to Queen's in Belfast, when I left the Commission for Social Care Inspection, I was heavily involved in a lot of work to do with children and families, and I was in another country, although it is part of the UK, in case people didn't realise that. Policymakers in Britain don't always realise that. So I thought, well, that I needed to find out what the landscape looked like in adult social care, because it was perhaps a bit less familiar than it used to be for me. So I decided I would spend a bit of time looking for randomised trials of adult social care or systematic reviews, and I didn't have a time to do a proper review myself. So I limited my searching for the last 5 years, and I was really trawling rather than angling, so there's the elements that are not so systematic. But I was really rather hopeful that I might find more trial evidence in this field than there has been in the last 10 years in children and family social work, where there has been a little bit of growth, largely replicating and evaluating programmes that have been imported, with apologies to our last colleague, imported from the US as so-called blueprint programmes. So they've already earned their spurs as evidence-based programmes to see whether they would translate into the UK context. So I was extremely pleased to come across this paper done by, it just seemed to me to be giving me exactly what I wanted. A meta-review, a review of reviews conducted by a group of very competent researchers at the Epicentre at the Institute of Education. And this is a paper published in 2015 that was based on a much larger piece of work that was commissioned by the Department of Health. And the DH wanted to know which social care interventions can effectively improve outcomes for service users, specifically addressing the 4 outcome domains set out in the ASCOF. The reviewers conducted their searches in 2012, and they defined social care interventions as anything that was led by or completely provided by anyone other than a healthcare professional. And that, I think, is a little bit problematic, and again, more anon. I'm going to show you 3 graphs from that study. This one shows you what kinds of outcomes were assessed across those reviews. And by the way, this study, this review, only used in answering its questions any controlled evidence from those systematic reviews. So as you can see, without even looking at the numbers of reviews that are looking at the effectiveness, controlled evidence, looking at the effectiveness of interventions to improve social participation or dignity and control are remarkably few. If you look at the interventions that have come under scrutiny, extremely small proportions of them have been concerned with things like personal assistance, or there's an other category which the rubric at the bottom tells you a little bit about. In other words, a lot of these interventions, although the review is about social care interventions, the bulk of the randomized controlled trial or other type of non-randomized controlled trial evidence are in areas that are really, well, you may have a different view, but I would argue a bit somewhat tangential from most of the areas that social care sees itself as being concerned with. The final diagram I'd like you to just take a very quick look at captures that, I think, in a different way. There are very, very few studies that are concerned with outcomes for people with mental health difficulties, for people with intellectual difficulties, and people with physical disabilities. Most of the effort when it comes to randomized controlled trial evidence has been invested in older people or people with chronic conditions. Now, those are important areas, but I want us to focus on what it tells us about the little regard and the little focus it's been given to other very important, very vulnerable in some instances groups. And the conclusion of these authors was that overall, we need to do better. Now, I should emphasise that these were not the only studies in these areas, but they were the only studies that came even remotely close to being an adequate study design to answer questions about what works. Now, reviews of reviews can pay the price in terms of a lack of focus or a lack of detail. So I thought, well, to be fair, let's go down a level. And I was, again, really pleased to find this paper. It's a systematic review of individual studies looking at health and social care interventions for what is, after all, an extremely important issue, that of promoting social participation amongst people with intellectual disabilities. The inclusion criteria were quite robust. The only limitation that probably was less desirable than any other was the focus on the English language study. But they took any design, and what they found, having done their searches 2 years ago, 11 studies, but this time no randomized controlled trials, although 4 of the studies were from the UK. In looking at the quality of those studies, perhaps not surprisingly given the absence of trials, the majority were found to be at moderate risk of bias. And the authors point to limitations like small sample sizes, lack of a control group, and again saying that for these people we need, for these interventions, for these outcomes, we need better and more information. What this slide, this summary slide, doesn't tell you is that some of the studies they looked at identified evidence of harm. So really quite sensible endeavours to promote social participation, in fact, in some studies did the opposite. Social care has probably been amongst the pioneers of involving service users and carers in research. Sorry, I seem to have lost a slide. Okay. Never mind. Before we go on to that then, please forgive me, there are some other problems that these authors identified which are much more commonplace amongst social care research. Poor definitions of social participation, poorly operationalised definitions of the intervention, a variety of ways of measuring what is ostensibly the same thing, the usual problems of selection bias and attrition bias, and a very small number of studies that provided follow-up data. I want to come back to this last point about losing social care and health again, but the point I want to make now is that both the papers, both the reviews I looked at, were talking about health and social care. But if you dig beneath the surface, 90% of the studies in those reviews were done by health professionals or looking at what were really either interventions that had health outcomes as well as social care outcomes, or were really on the fringes of health and social care. And I think if we're not careful, putting these two things together and letting health and social care trip off the tongue as we do, we are at risk of losing an important focus on what social care brings to the table. This is a summary of views which pretty much encapsulates what I think about the state of play at the moment in relation to social care. These comments were made in relation to research in the field of intellectual disability, but I think it's not too much of a stretch to give it a wider application. Enlightenment is not enough to satisfy the demands of evidence. New developments in social care are not necessarily advances, and ethical concerns over capacity and consent constitute a denial of opportunity which is now at least regarded as disenfranchising. One of the ethical concerns in the field of intellectual or cognitive disability in social care is that of informed consent. And I would want to suggest that we overcome the challenges of informed consent every day in terms of practice. and we ought to have, and do have, I think, the skills and imagination to overcome them in research. This was a slide I thought was coming earlier. We have rightly pioneered the involvement of service users in much of what we do. And so I was, again, seeing in the title Health and Social Care Research, interested to see this paper about looking at whether the involving patients and public in this research process actually made a difference to the delivery and quality of research. And this paper identified some 66 studies in which people, patients, service users, and the public had been involved in social care research. And the conclusion was that the research process seemed to benefit quite a lot at all points, from designing research questions through to steering the projects and interpreting the findings. But again, most of those studies were actually of healthcare studies and not social care studies. And I think if we're to maintain an edge, I know it's not a competition, but if we're to maintain an edge in our commitment to involvement in this field, then I think we need to up our game a little bit. So in terms of where I think we are in adult social care, we're not where we thought we were, and I'm not quite sure where we should be going, but what I do know is that we can't just keep doing the same thing over and over again. And by doing the same thing, I don't just mean eschewing the use of randomized controlled trials to answer questions about what works, but I mean doing those trials, taking the issue of doing randomized trials much more seriously and thinking about commissioning, designing, and implementing them much more carefully. I talked at the beginning about our early failures in this field, and what I am very concerned about at the moment, as I see a handful of trials being undertaken in the UK, is that we are repeating the same mistakes of yesteryear, and that, as with yesteryear, people will again conclude that it's not the implementation that's the problem, or the commissioning that's the problem, but it's the methodology. And I want to propose, it may not be a popular suggestion with such an audience as this, but this is one area where we do have an awful lot to learn from health. And the lessons that I've learned over the years from health are these. First of all, RCTs are technically possible, but they're challenging wherever you do them. And it's a myth to think that they're straightforward in health. Sure, there are some areas where they're easier than others, but there are an awful lot of areas where the challenges of doing RCTs in a healthcare, a systemic setting, are equally as challenging to anything we might do in social care. What I've also learned is that there is extremely important work to be done upstream before we even consider launching an effectiveness trial. And that's what I meant about the other when question. The sorts of things I mean are developing a theory of change or a logic model, getting clear in our heads what we think the model of change is, developing a plausible and defensible model of how programs can be expected to work. We need to spend time getting the intervention right. The number of times I've been involved in trials where the intervention is not evaluation ready is now somewhat embarrassing. We need to test the feasibility of something before we even go to a trial. Trials are very expensive, and when they don't come off, it's a lot of taxpayers' money down the drain. But very often in health, people take the time to test whether this intervention will actually be acceptable to people, to professionals, to service users. Can we deliver it the way we think we can deliver it? Will it operate on the ground the way we expect it to? We need to spend time choosing the right outcomes and the right measures. And development of core outcome sets in key areas of health, getting agreement between researchers, patients, service users, carers about what are the right things to measure is something that our healthcare colleagues are way ahead of us in. And even where we have made progress, as in the very excellent work that Anne Netton and her colleagues have done in developing a quality of life measure that's appropriate to social care, those are not always being used. The review I talked about earlier concentrated on health-related quality of life. And getting the right team together, including people who use services, but also including people who have content knowledge as well as methodological knowledge. I want to talk about some of the challenges that we need to face if we're going to turn this ship around, even if I could persuade you that randomized trials are the right direction to be going and to be doing more of. There are certainly ethical issues. I've mentioned the ones around informed consent. And I'll come back to it in relation to funding. But one of the things that is particularly difficult, I think, in doing a trial is getting all your ducks lined up in a row. I've been involved in a couple of trials recently where, in fact, the problem hasn't been professional antipathy to the research design. But senior managers have been very keen and have signed up their organisations, their local authorities to the trial. But the social workers on the ground have been conscripts, not volunteers. And we really needed a year to do the important hearts and minds work required to get those organisations, to get those local authorities, to get those teams in a position where they would be able and willing to deliver the intervention and deliver the information for the trial that we required. And of course, people are up against it very often in social care contexts. And even if they want to, finding the time to collaborate with researchers to make the success of a study, and I think that applies to all studies, not just trials, is really very difficult. And that, I suppose, takes me on to the third really big challenge, but also a lesson, I think, it's not so much a lesson learned, but a lesson we need to somehow transfer to the funding of social care trials. Funding envelopes are never so large, it seems to me, for social care trials as they are for healthcare trials, or studies, if you like. And that's always been a bit of a puzzle to me, because outside of the very technical, the very costly bits of healthcare that are legitimate laboratory costs, for example, the actual time it takes to set something up and to run it successfully in terms of the research infrastructure are not really that different. The NIHR, not this NIHR bit, but the other bits, will fund the intervention if it's an NHS intervention. And one of the big challenges to running RCTs in social care is finding the funding for the intervention. And also, the NIHR will back fund some of the resource implications for running a trial if there are extra staffing resources within the NHS. There are no such costs available to social care researchers. And when I last asked the chair of the Public Health Committee whether this was likely to change in the near future, he thought probably not, although I think he's quite sympathetic to the view. But it seems strange to me that we're increasingly recognising the interrelationship between health and social care in terms of public health, but this whole system seems very skewed against the funding, the adequate funding of successful trials in social care. And of course, there are policy pressures. We heard about them from the last speaker in terms of concerns about elections. But there isn't quite the same pressure, I think, in health to deliver a quick message on a particular healthcare intervention. There might be on policy-oriented or systemic interventions. But we are under a great deal of pressure, I think, sometimes to deliver quick answers to policymakers. And the lessons from health for me in delivering successful trials, we have to find a way of slowing that process down a little, particularly given that to do a trial successfully in social care, of the kind that were appearing in these reviews that I was referring to earlier, do take quite a lot of time. They take quite a lot of time in the planning. They take a lot of time in the setting up. They need a lot of contingency planning, and they need time because our populations are often smaller. We need longer periods to recruit adequate sample sizes. Outside of areas perhaps like mental health might be the exception. So I love this quote. I despair that it's nearly 50 years since it was written. We ignored Frederick Seabohm then. We've continued to ignore him and other advocates in social care. But for me, the issue of randomized controlled trials in social care is the big ethical issue. Not for the reasons that people say they can't or shouldn't be done, but because if we don't deliver gold standard, and I'm not going to apologise for using that word, there is a hierarchy of evidence. If we don't deliver gold standard evidence for the most vulnerable groups in society, then, to paraphrase Barbara Wharton, we're doing no more than dabbling our fingers self-approvingly in the stuff of other people's souls. And we should stop. That's it.
Don't have a lot of time for questions, but if there's anyone who's absolutely bursting, then we can maybe take one question for Geraldine. No? Okay. Geraldine, come to York. I'll introduce you to that trialist that gives everyone a bad name.
Okay.
Okay, if I can take this opportunity then to welcome John, our final speaker. John Glasby is Professor of Health and Social Care, and he's head of School of Social Policy at the University of Birmingham. I'm sure not a stranger to most of the people in the room. He's a social worker by background, does lots of work that spans health and social care at both the research policy level and also at the level of trusts as well. So lots of experience, and I'm really pleased that he's come to kind of round everything up for us today. And John's going to talk to us about what's next for adult social care, which we will all, of course, be desperate to know. So thank you, John.
Thanks very much, and thanks for inviting me to be here this afternoon. When I was talking to Mike Clark yesterday about this, he was teasing me that they put me on last to try and make sure that as many people as possible stayed to the end, which is a very nice thing to say, but of course it raises the pressure on you as a speaker. And then I started to reflect, would I stay to the end if it was me that I had to listen to? And that's probably not a very healthy question for any speaker to ask themselves. In the sessions that I've been in today, I've really enjoyed the sessions, and we've focused in detail on some of the studies that the school has commissioned, the impact that it's made. And I wanted to move out from some of the detail of those discussions to look at some of the challenges and the opportunities that we face in the current policy context, and to ask this question, well, where next for adult social care? I wanted to begin with an image which was first shared with me by Simon Duffy, very involved in the personalisation agenda and the person who set up the Centre for Welfare Reform. And there are a number of people out there, you might agree or disagree, who argue that the current adult social care system in this country is fundamentally broken. You might argue that the image of a train wreck is a little harsh, but a sense in this picture that something major has gone wrong in a system somewhere, and that something equally major might be required to try and put it right. Tinkering around the edges wouldn't be enough to solve a problem of that kind of magnitude. Now, people who say the system is fundamentally broken don't blame people currently working in or running adult social care services. They don't necessarily blame current or recent policymakers either. But there is a school of thought that says we've simply still got a very 1940s, 1950s system that was designed with 1940s aspirations and society in mind, and that over time has felt increasingly unfit for purpose in terms of how we live other aspects of our lives in the early 21st century. One of my PhD students saw this image, and he tells me it's a French train, and that the reason it crashed out the first-story window is they were running late, and the driver went too fast and then couldn't slow down quickly enough. But a contributing factor, ironically, so this PhD student claims, is that the guard, who should have been paying attention to what was happening and who could have intervened earlier, didn't, because he was so busy trying to catch up on his paperwork that he missed a trick, which, if you ever needed a metaphor for some of the barriers and challenges that we face, I think is an interesting one. What I wanted to do in this session was draw on some work that we did, some thinking that we were asked to do by Birmingham City Council initially. We produced a policy paper a few years ago now, as councils around the country were trying to grapple with the financial challenges that they were facing. And like all academic projects, it had to have an overly grandiose title. So this was our Turning the Welfare State Upside Down project, which was really trying to help Birmingham and other local authorities think through the kind of approach to adult social care they took in future in the current policy and financial context, and the kinds of conversations that they had with local people and with local communities and with staff as they were trying to think through the nature of that approach and that offer. And that report's free to download online if people are interested in the detail. What I was hoping to do in the session was talk very briefly about our recent history in adult social care, some of the current challenges, some of the kind of key concepts or alternative traditions that we might draw on, scope for a new approach going forwards, and really ask a question, well, what's holding us back? We don't always have a lot of evidence with some of the challenges that we face about what might work, but we do have quite a lot of evidence about what doesn't work sometimes. And part of me wonders, rather than waiting for new evidence before we do anything, sometimes we've got to give it a go and learn by doing and reflecting as we go along. We've described that as practice-based evidence rather than necessarily traditional notions of evidence-based practice. If I had to try and summarise a little bit of where we've come from in a slide and in a couple of minutes, I'd probably emphasise some of the bullets behind me. I tend to specialise in working at the boundary between health and social care. I was a social worker running a health services management centre at the University of Birmingham for many years and focusing a lot on joint working, partnerships and integrated care. And we have a very separate system of health and social care in this country that assumes that it's meaningful and possible to somehow distinguish between people who we see as being sick, and those are people that we label as having health needs. They're the responsibility of the NHS, and those needs are typically met free at the point of delivery, from people who are somehow merely frail or disabled, and those people we label as having social care needs. They're the responsibility of local councils, and the support that's provided is means tested, and people are charged sometimes very significant amounts of money for the cost of that care. Now, I don't know if that distinction ever made sense, but it certainly feels over time in an era of long-term conditions and with the demographic changes that we've been experiencing, that breaking the world down into health and social care like that just doesn't feel a very meaningful way of thinking about the work that we do and the level of social need that there's out there. But once you've got that separation, and once it's hardwired into some of our systems and some of our assumptions and our worldviews, we've learned the hard way. It's very difficult to overcome those barriers. And we have a whole history of attempts of trying to integrate these services more effectively, which have tended to over-promise and under-deliver, in my experience. There have been some major steps forward and there have been some real positives, but it's been really difficult to achieve. And there's a very famous article on the 5 laws of integration, one of which is that it's quite difficult to integrate a square peg into a round hole. And many local areas have found over time that actually trying to be integrated in a policy system that wasn't designed with integration in mind can be very challenging on a long-term basis. One of the implications of that history is that when money's tight, rather than pulling together to work jointly on shared priorities, there's a risk of people pulling apart and a vested interest in me shunting costs onto you and vice versa. And of course, when that happens, it's not just the cost that gets shunted, it's also the person that cost represents. And if you talk to older people in particular who've been on the receiving end of that kind of behaviour at local level, who've had services arguing over whose responsibility the person is, but not arguing because the service wants the older person, arguing because they think someone else should take responsibility. You know, older people have told me just how soul-destroying and disempowering and damaging that feels. Cost shunting is a very neutral word, for something that's actually about shunting the person, not just the cost. Of course, the boundary between health and social care has shifted dramatically over time, and many things that would once have been provided free by the NHS have over time become part of means-tested adult social care. And I would argue, and I think many would, that the funding of the respective services hasn't necessarily followed on. We've also, I think, in both health and social care, got a very crisis-focused approach, a very hospital-centric system in the NHS, and a very institutional history and a focus on crisis intervention in adult social care. So my own view is that if there's something quite significant wrong with you, or if there's an emergency, you tend to get quite a good response. But often we've struggled to provide more comprehensive approaches. So in a worst case scenario, we've left people denying them access to support until they have a major crisis in their health, at which point all the resources of the system kick in and you can tend to get a very good response. And over time, and Josh said you've been doing it since the mid-70s with attempts to rebalance the system so that we invest in prevention and we invest up front. As we'll come on to a little bit later, we've really struggled to do that at scale in practice. In my view, we've got a very unsustainable system of long-term care. We've had ongoing debates about how we should fund long-term care as a society. To me, we still seem no closer to resolving those debates, and it feels very much as if it's been kicked back into the long grass again. And we've got a series of tensions in a mixed economy of care that are growing for the providers of those services, with I think some quite major concerns about the financial health of some of our service providers. I was very involved in work around care home closures at the time of the Southern Cross debacle, and it really did demonstrate quite how vulnerable some of our services were. We've also, I think, and this has come up several times today, had a very paternalistic ethos in welfare services more generally over time, a sense that the professional, often the doctor, given the building that we're in, knows best. And actually, adult social care for me has been at the forefront of attempts to articulate a different way of thinking about welfare services. And then finally on this slide, we've also tended to be very input and process-based. We've often measured things that are easy to measure. So we've looked at the quality of care homes in terms of the size of the rooms, or the number of rooms that are en suite, or the proportion of staff that have NVQs, without necessarily being able to say, well, actually, does any of that make any difference? What's it actually like to live there? That the focus is on the inputs and the processes that you can count, rather than necessarily on the outcomes. And in the current context, we face a series of challenges which have come up today. Chris and Lynn in particular covered these this morning, the demographic changes that we're experiencing. And I agree fully with Jill that actually the fact that we've got increasing life expectancy, I think, is a major achievement of our welfare state and a major cause for celebration. We shouldn't allow it to be portrayed as somehow being a burden on society. We've got a series of social changes in terms of how families live their lives, a series of technological changes which have changed both how we can work with people, but also changed people's expectations and the way that they want to interact with services. And someone once said to me, it's a little bit like the high street travel agents that you used to go to book a holiday. You'd go in and you'd physically book it there and then. The person would write it out by hand with those booklets that had the blue paper in, and they'd keep a copy and rip one off and give it to you. And this person's argument was that the adult social care system still felt a little bit like that kind of 1980s high street travel agent in terms of some of our ways of working, and hadn't moved on in perhaps the way that something like the tourism industry has. We've got changing public expectations and a very, very difficult financial context. In Birmingham, where I live, our cabinet member for children's services commented on the 50 million or so that Sport Relief raised recently, saying that was a wonderful achievement, but pointing out that Birmingham City Council alone had to make cuts of twice that this financial year as a result of their financial settlement, and they've got to do that for the next 3 financial years after that as well. So effectively, with more need and with less money, something fundamental has got to change. And you see that in a range of different ways. This is a quote from Paul Burstow, the former Care Services Minister and now an honorary prof at Birmingham with me. And Paul had said, well, social care is facing tough times. Social workers are deployed principally as border patrol, policing access to increasingly insufficient resources against a growing clamour of seemingly limitless need. The only access point is a humiliating demonstration of vulnerability and dependency. It's a deficit model that's dominated practice and policy for decades, yet it's clearer than ever before that it's unsustainable. And lots of other people have said similar. Alex Fox from Shared Lives quoted a carer who said, look, I shouldn't have to spend my life proving that my son can't do things to get the support that my family needs to help him do things for himself. And so on and so forth. I think these slides will be made available afterwards, and there's a couple of quotes that I'll just skim through that say the same thing effectively. And I think my argument would be that the usual responses that we've come up with over time haven't necessarily worked in the way we hoped. There's been some really promising developments, but I don't think we've systematically been able to rebalance the adult social care system in a way that possibly policymakers might have hoped. I've just picked three here. One is around partnerships between health and social care. That's been a long-standing aim, at least since the 1960s, if not before. But we have really struggled to achieve it in a meaningful way top-down. And too often we've focused on structural changes, I would argue, and organisational changes, and probably paid insufficient attention to issues of frontline interprofessional practice and the time and the relationships that are needed to join up care around the needs of individuals. Cynics have sometimes described partnership working or integrated care in different ways. Someone described it as the indefinable in pursuit of the unachievable, paraphrasing Mark Twain. Someone else described it as the setting aside of mutual loathing in order to get your hands on someone else's money. And then from the business literature, someone described it as partnership working is very much like cottage cheese, they said. It separates easily and sometimes it smells bad. Now, working together has clearly got to be part of a solution for many of the problems that we face. And this morning we heard that almost none of the problems that we encounter have single agency responses. But I do think there's a belief out there that we can both improve outcomes for individuals and that we can save money through more integrated approaches. And at a system level, we have struggled to do both of those at the same time, as have many other health and social care systems in other parts of the world. Developing a more preventative approach has clearly got to be part of a solution as well. It kind of just intuitively, that's got to be right, hasn't it? But again, we've really struggled. We've tended to have small-scale or time-limited pilots, and we've really struggled to mainstream some of what's worked. And even when we have, we've tended never to do it at sufficient scale to really rebalance the system away from its historic crisis focus. For researchers in the room, there's also a key challenge there, I guess. Proving that you've prevented something is very difficult. You know, effectively, either practitioners or researchers have to prove to the satisfaction of the people with holding the money, the strings to the purse, that something bad that would have happened hasn't happened because of an intervention that you made. And had your project not been there, that thing would have happened. I mean, that's a really difficult sentence to say, actually, let alone a difficult sentence to prove in practice. We've also heard today how the timescales for policy are often very different to the timescales that you need to genuinely embed a preventative approach. I was a little depressed when 12 months into Sure Start, some of the early data was published because policy makers were under pressure to demonstrate whether or not it had been a success. Well, if the logic model that Geraldine referred to is about working with young parents and parents from disadvantaged backgrounds to make sure that the children that they have grow up and actually things change over the generations, you know, in one sense we won't know whether or not something like Sure Start worked for 16 to 18 years plus. The idea that you could know within 12 months just doesn't make any sense to me. At the same time, if you were the politician responsible for that policy, you couldn't stay to the media or to a public audience, well, we've spent all this money, come back in 18 years' time and I'll tell you whether or not it's been money well spent. The timescales are different. And then finally on this slide, I do a lot of work around the personalisation agenda, and I'm a key advocate for this way of working. I think it's really promising and really genuinely exciting. I know there's different views in the room, but my own personal view is if adult social care can't get a bit passionate about personalisation, I don't know what we can get passionate about. But as I go around the country, I see it implemented in all kinds of ways, some of which seem very inconsistent with the underlying value base of this original approach. And Simon Duffy, who I quoted earlier, described this in a wonderful phrase as a kind of form of zombie personalisation. From a distance, it kind of looks like personalisation, but you get up close and actually it's a pale and a slightly sinister imitation of what real personalisation might be, zombie personalisation. So if some of those approaches are maybe promising but perhaps haven't delivered in quite the way we wanted them to, are there alternative approaches? And in the policy paper, Turning the Welfare State Upside Down, we argue that there may be some potential in terms of more asset-based or more strengths-based approaches, rather than trying to focus on what's wrong with people and intervening to help them put that right or to manage that deficit. Are there ways of acknowledging what people can already do for themselves and building on ways that people currently live their lives with the community resources that they access and the networks that they have available to them and so on. And there are a number of alternative traditions for colleagues from academic backgrounds that speak to some of this. The notion in the literature of social capital. For colleagues from a community development background, the notion of ABCD, assets-based community development, public value. A lot of the reforms in disability services have come not from social care, but actually have come from an independent living movement that has campaigned for greater citizenship, building on the inspiration of other civil rights movements. And the personalisation agenda initially actually came not from government, but for me came from, I suppose what I'd call more of an inclusion movement within learning disability services, drawing very explicitly on notions of social justice and citizenship. We don't need to necessarily take a deficit-based model. There are other traditions out there. And so in the policy paper, we started to explore with Birmingham in this particular case, are there ways of building on social capital and community resources so that what the state can do builds on top of what already works well for people, rather than ignoring that, or in the worst case, actually riding roughshod over it. And we talked to a number of local authorities that were trying to experiment with these ways of working, and we talked to a number of national stakeholders who'd been thinking about and working on some of these issues for many, many years. A number of them saw it as a return, at least in part, to some of the community development origins of adult social care. And they saw that as a good thing, although they also felt it brought major cultural challenges for local authorities and for national policymakers. When we looked around the country, we found lots of really interesting examples that seemed to be really promising. I think one of the questions in the plenaries this morning mentioned local area coordination. We saw some really interesting examples of micro-enterprise working in very different ways in communities. We saw time banks thinking about different ways of trying to support people with social care needs. We saw some really interesting examples from Shropshire and from Surrey. In Shropshire, the reablement service was trying to reable people not through a system of professional support, but through a system of peer support, with social workers being seconded to community organisations and working in kind of high street shopping locations rather than office buildings to try and think about reablement. In Surrey, the local authority was trying to say to people, at the moment you go into people's homes and you assume that 100% of the need that we try to meet will be met by the local authority. What would happen to a typical family in our area if you went in with an assumption that we'd meet 85% of the need, but that 15% of it might come from community resources? Now, they were really keen to say that doesn't mean that people don't have access to community resources, only get 85% of a service. But actually, if you switch your mental model from 100-0 to 85-15, what would that actually look like in terms of outcomes for people and how we might approach things? And a number of local authorities starting to think about the link with economic development, rather than making a claim for social care funding as a kind of basic safety net, saying actually, could this be a form of social and economic investment in people and in communities? And in an extreme example, I guess the micro-enterprises that we worked with were very clear that they felt that they were working in some very impoverished communities, and a number of the private providers that were working in those areas were often owned by big multinational companies. So the council was spending all this money on care that was then leaving those communities straight away, and sometimes even going out of the country. Was the way, as those enterprises were saying, of spending that social care money, but so that the money stayed in the local community to benefit that community and not just the person that was receiving the service. And the City Council in Birmingham got quite excited about this. They wondered whether there was scope to focus. Initially, they were going to focus on a case study family. What would it look like if you worked like this with a particular family? In the end, they decided that in the future they'd like to do this with local citizens and with staff, focusing not on a family, because lots of areas do that these days, but focusing on a street. What would happen if you took a typical Birmingham street or a typical Devon street or a typical Newcastle street? From the public health data, who lives on that street? How much money are we spending on social care for that street at the moment? And how many people are benefiting from it? How many people live on that street that have got needs that never come forward? And how many people live there that have got needs that come forward but get turned away? And then actually building on that, could you think of more imaginative ways of using that money so that everyone on the street benefited from it, rather than just the individual recipients of the care package? I got quite fired up. Coming from Birmingham, I wanted to call it Chamberlain Street, just given the history of the city. But it was quite an interesting way of not just thinking about new approaches, but also thinking about ways in which local authorities could have that conversation with their staff and with local people. Finally, though, the key question is, well, what's holding us back? Josh said that many of these initiatives and approaches aren't new. We've been talking about them for decades. What stopped us doing some of them for real? You know, one of them's a key question. Will it actually work, John, was something the council said. And actually, we can't afford for it to fail. We haven't got enough money to meet our statutory responsibilities. We can't afford to invest money in something where we don't know it'll work. A key question, I think, in the current context, and I have no answer to this, if I'm brutally honest, how do councils implement the cuts that they have to make without cutting the wrong things? If I was faced with the 250 million savings I think Birmingham has to make over the next 4 years, I'd probably do things that I know run counter to the argument I've made in these slides. You know, I would be laying off neighbourhood workers because there'd be less protest and fewer people would notice early on. I'd be closing expensive area offices in local communities where I couldn't afford to maintain the buildings, and I'd be centralising everyone in purpose-built hot desking kind of environments. That's just the kind of thing you'd probably end up doing to save that amount of money. It probably runs entirely counter to some of the things you might need to do if you wanted to embed a more asset-based, more community-based approach. So many of the local authorities we spoke to could see where they wanted to end up in 10 years' time. They couldn't see how they got through the next 3 or 4 years without shooting themselves in the foot by cutting the wrong things, in inverted commas. Some really interesting questions about whether we've got the skills and experience to do this anymore. A number of people saying this used to be what social care was about, but it hasn't been for some time, John. And one national stakeholder, pulling my leg slightly, said, for years you've been training people, John, as community development workers, and we haven't wanted you to do that. We've wanted you to train people as care managers. 20 years on, and you've finally caught up and you've started training people as care managers, and now we're asking you to train them as community development workers again. Now, he was pulling my leg, but there was just this lack of fit in terms of the timescales and the trends in terms of what employers want, what policy has wanted, and the kind of skills and experience that the profession might need. So if these skills exist, do they exist in social care anymore? Maybe they exist in the third sector, maybe they exist elsewhere in local government. A key challenge that's come today, David mentioned this in our group earlier, about how do we scale up to do this at sufficient scale to make a difference. And the micro enterprises that we were working with said it's not about scaling up. Sometimes when you do that, you lose something really distinctive and important about what you were trying to do. It's more about scaling out than it is necessarily about scaling up. And I felt that was a really helpful distinction. And then crucially, in the current context, what will staff and local people make of this? The real risk, I think, for me, is that a local authority, for all the right reasons, tries to develop something that's more assets-based, tries to build on something that's more strengths-orientated, but actually gets taken to judicial review by staff, by trade unions, or by local people, because it's seen as cuts. It's seen as a negative intervention, when actually it was intentioned as a way of trying to build on social capital and community resources. So that's a very, very rapid trawl through what next for adult social care. I don't think that's a prediction necessarily, but there are a number of interventions that have been promising but have only got us so far. My argument, I think, going back to that train wreck image at the start, is that if something major has gone wrong, then maybe something equally major might be required to try and put it right. I don't know whether more asset-based approaches would work. But for me, they feel like they've got to be part of the solution. And going forwards, I suspect it'll be people in this room, as well as the School for Social Care Research, that help us test some of that out and try and deliver it in practice. So thank you very much.
Unfortunately, I don't. Marty's pulling faces at me, so we probably haven't got time for any questions. I know Marty wants to have 5 minutes. But can I just take this opportunity to thank all 3 of our speakers for the plenaries this afternoon? I think they've been absolutely fascinating. I've really enjoyed them. So if we could just thank all 3 of them once again.
And I'm going to say something controversial, which is I think, although I'd loved having questions and discussion and so on, it's been great hearing 3 very, very good presentations, full of stuff. They all had to rush at the end. The slides will be on the website, so please do take an opportunity there. And I'm sure they won't mind being contacted by email if you wanted to get some questions to them. So 4 things to say very quickly. I don't want to delay us getting out of here. So what I've just said, presentations will be on the website and the video as well. We'll get them up as soon as you can, and please do engage with the speakers. I'm sure they will all be very happy from the plenaries and the other groups. Secondly, great. Everybody who comes to these conferences says they're great, and we hope to have another great one next year. We haven't fixed the dates yet. I know many of you organise your holidays and family life events around our conference. In fact, we even had to get Easter moved this year to fit in around. So please look out for the thing for next year. Thirdly, out of the 4, the Hunterian Museum, which I think is upstairs. I've been there before, but I think it's upstairs, is open until 5 p.m. if you want to go. If you want to go and look at bits of body parts that have been taken out and so on. It is quite interesting, but some bits I didn't like very much. And then fourthly and finally, a big thank you to a number of people. Firstly, to the speakers. I know, we all know, when you give a presentation, how much work it takes to get a presentation together. So the ones I've seen have been brilliant. They've been really helpful, and I hope they'll be useful to you when you see them again on the website. So thank you to the speakers. Thank you to the chairs who kept us in order. Thank you to the organiser, Angie, who I'm sure is out of the room because she always knows I'm going to thank her and she disappears at that point. But Angie does this thing almost on her own, it seems, and organises a very good conference. And thank you to you for coming along, for listening, for asking questions, for engaging with this. And I hope, thank you for using what you found today in the future. So please do thank everybody and go home.